Hello, and welcome to Day 2 of PPMD's 27th Annual Conference Virtual Edition. I'm Ryan Fisher, Chief Advocacy Officer at PPMD.
And I'm Eric Camino, PPMD's Vice President of Research and Clinical Innovation.
So here we are, Day 2. If you happen to miss Day 1, not to worry, you can go to the virtual hub and find a recording from all of yesterday's presentations. We've really had a great day yesterday as a first day for a conference. We had a packed agenda. We started with a message from PPMD's board chair, Inessa Faisenfeld, and then we had a message from PPMD's founder and president, Pat Furlong, to officially kick off the conference. It's great to have Pat here in the studio this year.
It definitely is. We also had a number of great conversations about clinical trials. We had our first two into the pipeline sessions talking about restoring dystrophin and protecting the muscle. And in those conversations, we spoke with sponsors developing investigational products or approved products about various topics. With restoring dystrophin, we talked a little bit about how we follow patients long term. And with our protecting the muscle, we had a little bit of a discussion about those underserved populations, our older non-ambulatory patients or Becker patients who may be able to, receive some of these therapies. And we also had our first recently reported updates session where we were joined by Dr. Paula Clemens, who gave a presentation on some of the phase 2 data from the the open label extension with Viltepso.
Yeah, it's really, really important to hear about what's happening with these approved therapies. Getting this data out there is critical to not only the physicians who are treating patients, like we heard from Dr. Eddie Smith yesterday, but the patients deserve to hear what's happening with these therapies so that at the end of the day they can make the most informed choices possible for themselves or their loved ones. So it was a really good discussion with Dr. Eddie Smith. And on the Protecting the Muscle panel, it's great to hear companies that are investing in trials for these underserved populations, like the Becker community and non-ambulatory patients as well. We want to see more companies entering this space as the characterization of disease matures and we understand more about how to study these populations. We're going to continue to advocate for them to do trials within them. So, we know that we covered the exons that currently have approved therapies, but we also understand the urgency for those who don't have a therapy in trial for their exons. So once again, we're going to keep beating that drum to companies to develop these therapies and to be open and transparent about their timelines. So Eric, what's in store for today?
Yeah, we have another packed agenda tonight. We have our first care panel. So we are going to be hearing from some professionals talking about GI health and nutrition. We have another pop quiz coming your way. We also have our Into the Pipeline series talking about gene therapy this evening. And then we're going to be joined by Dr. Craig McDonald a little later this evening to get some recently reported updates about PTC Therapeutics and their product Deflazacort. And then as a reminder, our Adult Advisory Committee, the PAC, is going to be hosting a virtual Zoom social for teens and adults tonight. So that's 14 and up. And with that, I'm going to pass it back to Ryan for a little bit of housekeeping for today.
Great. Thank you so much, Eric. So, some reminders. The PPMD Virtual Annual Conference Hub is your go-to spot. This is where you can find all information, including pre-recorded videos from many of the presentations that you're going to hear over the course of the next few days. You also can you can also find a recording from yesterday. We also have a poster session and a vendor fair you should check out. You can register for one-on-one sessions with our genetic counselors, as well as experts in behavior and learning, and finally, physical therapists. And as Eric mentioned, we have our social nights. That's where you can actually register for the Zoom social nights. So be sure to check that out. We want to take a moment to thank our sponsors. Tonight, we're giving a shout out to our gold level sponsors, Daiichi Sankyo, Edgewise, REGENXBIO, and Roche Genentech. Thank you so much for supporting the conference and for all you do. Another reminder, we have the daily photo challenge. Today's theme is summer style. We've included a pair of sunglasses. Send in your photos. Some of you have already done this. Keep them coming. We'll have a winner at the end that we choose, and we'll provide a $25 gift certificate for that winner, and we'll announce them at the end of the day. So we're going to start today with a bit of polling. Some of you may have done this yesterday, but if you haven't, you just need to go to pollev.com/PPMD in order to participate. We're going to pull up the questions. These are questions for families, remember, and we also have a pop quiz at the end. So, first question is up. Which statement best describes your decision-making process for enrolling in a clinical trial? You have several options to choose from here. I'll give you a minute to read.
Yeah, we're always interested to see how families are learning about trials and deciding what ones to participate in. These can be difficult discussions. There's a lot to learn. There's a lot of information out there. We, of course, have some resources on the PPMD website, such as our interactive pipeline and our Explore Clinical Trials tools to help you make those decisions. We also always recommend, talking with your care team. They're going to know, what might be some good fits for you as well. But we just kind of want to learn how you out there are kind of making these decisions.
Again, you can go to pollev.com/PPMD to participate in this polling. More answers are coming in. I know that this is a lot to read through with the choices, but we see that many research all trials on their own, determine the best, and then to discuss it with their clinician, but others are making decisions still, and polling is still coming through. So we'll give it one more minute.
And we also know that these decisions are affected by different things. We know some families, are willing to travel quite some way to go to trials. Some want to find ones that are at their local institution. So all different ways that you can participate. But, just looking for how you do that with your family.
Wonderful. So we think we're going to move on to the next polling question, which reads, has your neuromuscular center spoken with you about clinical trial options or opportunities outside of where you normally receive your neuromuscular care?
Yeah, again, this kind of comes back to that topic about, we know that there's some institutions where a lot of clinical trials happen, but not all of you necessarily live in those places where you have those same opportunities. So just trying to get a feel for how often those conversations happen, are you learning about those trials? And that's kind of important as we think about trial design as well, and where clinical trial sites are kind of
Sure, and we saw from the last question that many who answered the polling research trials on their own, which means that the trial might not be happening at their given institution. So, I expect many will talk about these trials with their clinician, but does the clinician mention them themselves? This is the interesting part of this.
That might be a good follow-up question for next year of whether you're bringing this up in your visits or whether that's something unprompted that your physician's bringing up with you.
Sure. Okay, so I think we're going to move to question number 3. Okay, do you agree or disagree with the following statement? When I have questions about the science of gene therapy, I have enough educational resources available to me to answer these questions.
Yeah, and this is a big one for us here at PPMD as we think about what we need to do to help the community and help with education. We want to make sure that you feel empowered. Not just for gene therapy, but for all the therapies that you're considering. But we want to make sure you have those resources and they're readily available at your fingertips. Gene therapy is a complex topic, and different people have different understanding of science. And so we're trying to make sure that we're always providing content that can help you and your family understand and make decisions, no matter what your level of kind of science understanding is.
And it's true. And we're doing gene therapy panel later on. I felt it was appropriate to have some gene therapy questions. Some of you might remember these questions from the past. It's important for us to repeat some of these questions to see how answers might be evolving or changing. So that's why you may see a question that you have been asked before. Okay, so I think we're going to move to the next polling question. Oh, it's a pop quiz. So, what is the tiny piece at the end of a shoelace called something most of us don't care about until it frays or falls off?
Unlike yesterday's pop quiz, I actually know the answer to this one.
You do?
So,
you do?
Yeah.
Had no idea. Looks like answers are still coming in. Reminder, the person who answers this the quickest is going to win $25. And we'll just give it one more second. Okay? We're going to be able to actually reveal the answer in real time tonight to show you what the answer for the pop quiz was. And there it is. It's the aglet. You knew that, huh?
Yeah, that is the one I have known.
You're the scientist. You're smarter than me. Okay, so we're going to now move on. And Eric's going to take us to our first official panel.
Yeah, so our first panel for tonight is one of our care sessions. So we are going to be focusing on the topic of GI health and nutrition. And so we are going to be joined by Rachel Schrader, who is PPMD's Vice President of Clinical Care and Education. And joining Rachel on this panel, we have Kindon Fawcett from Arkansas Children's Hospital. We have Kent Williams from Nationwide Children's Hospital, and Kiara Bergen from Virginia Commonwealth University. So with that, Rachel, I'm going to hand this discussion over to you.
Great. Thanks so much, Eric and Ryan. I'm really excited. We have a wonderful group of speakers with us this evening to talk about the ins and outs of GI health. Really great panel, and I think that you're going to learn a lot from each of them. Please feel free to submit any questions that you have for the speakers throughout the course of the presentation, and we'll get through as many of those questions at the end as we can. So I think with that, we'll go ahead and jump right in. I'm going to hand it over to Dr. Kindon Fawcett of Arkansas Children's Hospital. Dr. Fawcett, take it away.
All right, thank you so much. It's so nice to be here today. So I'm going to talk a little bit today about, I'm trying to get my slides to, okay, there we go. Sorry about that. I'm going to talk a little bit today about nutrition and what we can do as providers and as family members for our boys and possibly girls if you have one. So just to bring a little bit to the table, I kind of have a dual role when it comes to this disease. I am a practitioner and I do research in nutrition and neuromuscular diseases, but I also have an 11-year-old son that has Duchenne muscular dystrophy. So I like to think that we try to practice what we preach. So on that, I will ask for my next slide, please. So we kind of have two different ways that we can look at it. You know, we can look at it from the clinician standpoint and we can look at it from the family standpoint. So what we can do when we go into an appointment is to really try to focus on what we're doing for our boys on the prevention side. So we're going to talk about three things today: weight management and health, the dietitian role, and then also the family role. So I'll take that next slide, please. Thank you. Okay, so what can we do and where do we go to find help? So with our weight management and health, we really need to know how many calories our boys need. So a great way to start out with that is to, number one, if your provider hasn't helped you find a dietitian, go ahead and advocate for yourself and ask to see a dietitian. So with that, they're going to talk to you a little bit about what our boys need caloric intake wise. And one of the best ways we can do that is with the Mifflin-St. Jeor equation, and that's going to give us our basal metabolic rate, which tells us what we need to just live and breathe. So that's without exercising, that's without, walking to your car or doing those activities of daily living. So that's a good way to start out. So we have a baseline of what our boys actually need, because an 11-year-old that is non-ambulatory in a wheelchair is going to have a very different BMR than a very typical 11-year-old boy that plays soccer. And then secondly, we're going to look at choosing the right foods and portion size. So a lot of times we have so many questions about, well, what kind of foods do my boys need to be eating? Do they need protein at every meal, et cetera, et cetera. So some things that we're really going to try to focus on are choosing foods with a high satiety factor. And that just means foods that keep us feeling full longer. So think about the difference of when you eat a Snickers bar and it feels really good for a few minutes and you feel good and you've got that really good energy, and then you kind of have that crash, which people call it a sugar crash or whatever you want to call it, versus when you eat a whole grain piece of bread with some turkey and some cheese, a sandwich that keeps you feeling full longer. So that's going to have a higher satiety factor. So things that keep us feeling full are whole grains, vegetables with fiber, proteins, and, foods that keep our blood sugar at a stable level. So fruits and vegetables, we say, kind of when we're looking at the My Plate, fill half your plate with vegetables. And then snacks, use fruits and vegetables as snacks, and try to stay away from those processed, bags, boxes, things like that. So also, I always like to add, when eating your fruits and vegetables, to eat the peel, unless it's, a banana or something like that. And then, like I said, a protein at every meal and snack, just because that usually gives us some good energy, and it helps us stay feeling full longer. And then limit or eliminate those sugared beverages. I'm not going to say that you can never eat a candy bar again, or you can never have a piece of cake or anything like that. But if you can try to limit those, and then also limit those sugared beverages, and then drink water. This will help so much in digestion and also help you feel fuller longer. So I'll take that next slide, please. So when to ask for help, we are really trying to focus, especially at Arkansas Children's Hospital, about getting us to a point before we need it. So on the prevention side, so trying to get our families in to see a dietitian before their sons have gained, 30 pounds since their last visit. So we always want to say, see a dietitian at the onset of steroids. And then we are really trying to change our standard of care and practice at Arkansas Children's to see a dietitian at those multidisciplinary visits, which for us, it's every 6 months. And then additionally, if that growth curve changes. So we see a lot with DMD that our boys' growth changes are higher. And then with our Becker boys, they tend to be on the lower end, a little smaller in stature. And then also other things to consider. So glucose metabolism, mobility issues. And this is one thing that maybe you don't think of until you're in that situation. When your boys stop walking, then their caloric intake changes. And then respiratory and cardiology, that's a hard one for me. Cardio functions. And then also looking at our undernutrition and our muscle function. So just like anything, you have to have enough food and good food and energy to keep you feeling healthy. And then other things that we'll talk about, GI complications, constipation, and fiber and water can really help those. Chewing and swallowing difficulties. And then some of the other things that we want to consider are calcium and vitamin D deficiencies. And one of the things that we had to look at when we were starting to look at some of the data of our boys, we were prescribing vitamin D to these boys. But if you don't have calcium with your vitamin D, sometimes you don't absorb it as well. And then we also want to look at those factors that affect osteoporosis and osteopenia. So making sure our boys are still getting some exercise and some weight bearing mobility. So I'll take the next slide, please. And then finally, just really talking about it as a family role. So I'm never going to tell someone that they need to change their eating habits, but for their boys, but nobody else in the family has to. So it's not like you can sit down to dinner and be like, okay, Timmy gets a salad with some grilled chicken and everybody else gets pizza. That's not the way it works. If a family wants to do this, we have to make it as normalized and as for the whole family. So it's just everybody does it. It's not we keep somebody kind of out of the loop. So like I said, we change the whole family's eating habits, and then we're going to unlearn those healthy coping and eating practices. So we did a research study and we found a lot of parents tend to be emotional eaters, or they give their boys maybe food to kind of cope with some of the other things that they're not getting. And I will be very honest, we've done that with our kiddos. Hey, I know everybody else is doing this. Hey, do you just want to watch a movie and eat some popcorn and have some, candy and stuff? So trying to really focus on really thinking about food as just energy sources, not as a reward, not as a punishment, not as good or bad. And then also just stop that emotional eating. And we all do it, oh, I'm sad, I'm going to do this, or I'm going to do that. And then also incorporate the participation and learning about nutrition. So when you're in the kitchen, bring your boys in, bring your family and talk about, hey, we're having this for dinner. And let me tell you what nutrients a carrot has. I know my son's name is Tyler, and I know he really enjoys talking about that. And he's actually getting very good at telling us all when we're not doing a very good job eating healthy. He's like, now, I don't think you're supposed to be eating that, Mom. I think you had one of those yesterday. So he's kind of become the nutrition police in our house. And then also just being an advocate for your kiddo and your family. If you want to know more about nutrition, you can always ask to see a dietitian. And I think that that's something that maybe is a little bit unfamiliar when families come into clinic and into these multidisciplinary visits, because they don't know all of the things that are out there for them. So just knowing that it's okay to ask for things, or if you're unclear or you need some more guidance, we have plenty of it. And one of those other things with that is encouraging physical activity. I was just in a meeting with our department chief of neurology, and we were talking about how those micro tears are actually okay. For so long, we said, don't let these boys exercise, don't let these boys do anything. But now we're like, okay, it's kind of use it or lose it, use it while you can, because at some point you might not be able to. So physical activity is okay. So next slide, please. So with this is just a fun kind of little pictures of all of our family doing all kinds of stuff. So we have Tyler doing everything from basketball that we had at our youth center to a color run. That's me with the color shirt on, pregnant with our youngest. And then we went to an animal farm, and Tyler does everything with us that anybody would. It's just sometimes you have to make a few adjustments. So that was just kind of showing you guys that we get it. So if there's any questions, you can always ask me about it. Next slide, please. So nutrition is one of the most important things that you can do for your son, or if you have a daughter with one of these conditions. And it's mostly just educating yourself and not being afraid to ask questions. Next slide. Questions.
Great. Thank you so much, Kendan. We'll go ahead and save the questions for the end. So a reminder, everybody that's tuning in, go ahead, submit those questions, and we'll have great conversation. Thank you so much for those amazing points, Kendan. I think that, it's just such a great reminder that a dietitian, having that nutrition person on your care team, part of that multidisciplinary team, is just so important when it comes to really comprehensive and well-rounded care. So let's continue the conversation. Next up, we have Dr. Kent Williams of Nationwide Children's Hospital.
Hey, thanks, Rachel. So I'm a GI doctor. And so a lot of people through the years kind of got to know me as the poop doctor or the poop king, because I talk a lot of crap, but it's one of the things that really does help improve the quality of life of our young men. So next slide, please. So giving me only 10 minutes is very limiting to me. As many of you also probably know, as I like to talk a fair amount. So it's hard for me even to introduce myself in 10 minutes, more or less try to talk about GI issues in 10 minutes. But given that task, trying to pick the two topics that I feel like are the most important and then help to improve the quality of life best for a young man with Duchenne's would be bowel management and the timing of a G2. Next slide, please. So bowel management. I don't want to talk about treating constipation as much as I want to talk about bowel management. But constipation is very, very common in patients with Duchenne's. And it's not just common at the end of the life, but it's throughout the whole life. There was a study done by my colleagues at Cincinnati Children's where they looked at about 120 young men with Duchenne's, and they applied what we call the Rome criteria for constipation. Just randomly picked them. And what they found is that at least half of them met the criteria for constipation. Now, what was really interesting was that the constipation did not go up with age. It was not associated with age. It happened throughout the whole spectrum of life. And I think one of the big reasons is because a lot of the kids when they're young with the Duchenne's, they actually have a lot of the behavioral traits that go along with kids that have significant constipation, anxiety, OCD, autism, and different types of behavioral issues that predispose you to having constipation. Now, diet plays a role in it, and so having a good diet can help, but a lot of issues are more on having behavioral issues, sensory issues, and then later in life, trying to regulate your life so you don't have to worry about having bowel movements can get you in a lot of trouble. So it happens later. But of those half that they found that had met the criteria, about half of them had never been told that they had constipation. They were completely clueless about it, and it was just completely unrecognized, not only by them, but by their practitioners also. And you ask, how can that happen? If you don't, most people think of constipation being you don't poop. Well, let me show you an x-ray of a young man who pooped at least 2 or 3 times a day. Next slide. Now, I don't think you even have to be a doctor to realize that that thing in the middle is not normal and should not be there. And that thing in the middle is a big, large fecal impaction. That is all stool. Goes from the pelvis all the way up, pushing into the diaphragm, which makes it difficult for this young man to breathe. And as you can imagine, also makes it difficult to eat. When I first met this young man, he was losing weight also. So, but no one had ever diagnosed him with constipation. In fact, they thought he had problems with diarrhea, and that's why they were sending him to me, because he was having 3 to 4 loose stools a day, many of them out of his control. And they were worried that he was having like some kind of disease or problem going on in his colon, but it turns out he was severely constipated. So constipation is not just whether you go every day. In fact, there's a whole list of criteria. Next. Now, I don't want people to try to memorize every criteria. I'm going to give you that little cheat sheet that I use in the next one, but I'm just using this slide to basically demonstrate there's at least 7 criteria, 2 of which you have to be able to be diagnosed with constipation. And frequency is only 1 of the 7. Basically, you have 2 or fewer defecations per week. That's 1 of 2 criteria you've met for having constipation. But basically, if you're withholding stools, have large stools, having stool accidents, those are all criteria also. In fact, through my years of doing this with children, not only in Duchenne's, but autism and with other developmental issues, I've come up with 3 questions of my own that I always ask, seem to be pretty good in my clinic for trying to determine if someone's at risk for having constipation. Next slide. The first one, does your child have holy cow bowel movements? Now, if your child has constipation, significant constipation, you already know what I'm talking about. And usually a lot of times when I ask this question, parents go, yeah, then I know they already have constipation. But ones that have severe constipation, they're like, holy cow, what do you mean? What I mean by a holy cow bowel movement is your kid has a bowel movement and you go, holy cow. And you're either taking pictures to show it to somebody, or you're calling your wife or husband or someone in and look at it. I can't believe this came out of your mouth. It's like huge. So that's that very large stool. That study that I was talking about earlier, that was the most sensitive for being able to determine whether someone was constipated, is having very large stools. Stools so large, it's like they're giving birth practically. And if that's happening once, twice a week, and you have stools in between, you're constipated. The next one would be, how often do you go? And if you're say you only have 1, 2 bowel movements a week, then we'd worry about constipation also. The last one is, does your child seem to have streaks or smears? And in the younger kids, particularly ages 4 through 6, 8, this happens a lot. And the parents are like, oh, they just have a hard time wiping themselves. They just don't wipe well. Probably over half the time I find out the kids having streaks or smears in their underwear, though, it's due to constipation. Basically, the pressure builds up in the rectum and stool starts to leak out a little bit without them even knowing it. And it's not due whether they're being able to wipe or not at all. It's more due to the constipation. Next slide. So a lot of kids and young men are reluctant to be treated. They don't want to have a bowel movement. They don't want to have it when they're around other people that they don't feel comfortable with because they are dependent upon others to help them, or they don't want to have it when they're out in public. Next slide. But if you have a good bowel regimen, again, not treating constipation, but a good bowel regimen, it improves the quality of life. Basically, if you're still walking, you want to have good patterns, you're getting good habits. Good habits so that when you get later, when you're starting to not be able to walk as well, and when you're in a wheelchair, that you control the bowel movement, not the bowel movements control you. And there are various ways of doing this that we're not trying to treat constipation. We're trying to basically keep the colon healthy and improve your quality of life. We use a lot of stimulants where we use like a bisacodyl, a senna, like a chocolate X-lax, and we'll use large doses. And sometimes what I'll do is I'll do like, we're going to pick Sunday, Tuesday, Thursday. Those are the days we're going to do a big dose to try to have a bowel movement. We'll do enemas and suppositories. People are like, oh, that's got to be terrible. But usually when I ask a young man, it's like, okay, which would you prefer? An enema or suppository and what that means, or the risk of having a bowel movement and having accidents in your pants, and they're going to pick the enema and suppositories. Same with bowel cleanouts. This is done very easily if you have a G-tube. You give large amounts once every week or 2 weeks, just to basically clean out the colon and keep it going. And then if we're really having some issues with the medications by mouth, there are surgical options that are not truly invasive, but again, people are like very reluctant to do it because it's surgery, high risk or whatever. But again, if you ask the question of what would you rather do? Would you rather be in fear of having a bowel movement in front of your family, in front of your friends? You know, because basically a surgery, putting a tube in somewhere to flush out like a cecostomy, or to have a colostomy, which is back where the poop comes into it, that you put a shirt over, no one's going to know you have that. You poop in your pants, people are going to know that you just did it, and that's a more traumatic event. So there's lots of options. Again, we're not treating constipation as much as we want to get you into good bowel regimen to improve your quality of life. Next slide. So one way of doing that, like I said, it's sometimes with a G-tube. And this is the other thing that I see a lot to be able to improve the quality of life. Next. G-tube, you're able to give medications. We can, you know, it's nasty, some of the medications you got to take for doing bowel cleanouts. We can get right a tube and we can keep a very healthy colon going. Next slide. And then the other thing is, when you get a G-tube, it's not, we're talking about taking over your eating. We're talking about trying to supplement, trying to help you from being malnourished, because as Dr. Fawcett was referring to it earlier, in the malnourished state, you're going to adversely affect, you're going to cause, you're not going to be able to breathe. It's a lot of work to breathe. You're not going to have the energy to do it. You're going to cause damage to your heart being severely malnourished because your heart's not going to get the energy it needs to stay healthy. And then just not being able to focus and things. Next. So anytime you start having difficulty feeding yourself, whether it be with swallowing, chewing, or whether not being able to get the food there, then we need to talk about having a G-tube. Next. And if you're unable to maintain the weight, your weight starts to trend down. You need to watch your weight every 6 months at those visits. We watch every week. If you start to trend down, we really need to start talking about a G-tube. Next. And of course, anytime you're having problems swallowing, a risk for aspiration. Again, we're not talking necessarily you got to take everything by mouth, because maybe you're able to do the solid foods, but the liquids you're not able to do well. We use it as a supplement. Again, we are trying to improve your quality of life, not rob you of something. And of course, the last one, as I said earlier, is about for bowel management. Next. Next slide. Now, again, you're still able to eat by mouth, and people always worry about the surgical risk. But once you start losing weight, once you start having complications from Duchenne's, the risk goes up. It's never really too early to start thinking about this once you start having some of these issues. And again, I can't tell you how many times people come to me afterwards and say, you know, I really don't want to do it, but man, my life is so much better since I've had this G-tube. It's so much easier. I don't have to take 2 hours trying to eat. I can keep my bowels going regularly by the medications we can give, plus the fluids and the other things. My concentration is so much better. I'm able to enjoy things more. I have so much more energy. Definitely improves the quality of life. Next. Thank you.
Wonderful. Thank you so much, Dr. Williams. I really love that last point, and I'm sure it'll come up in the conversation that G-tube can make such a significant difference in just quality of life, because you don't have to worry about shoving in those calories. You can enjoy the ones you want and, you know, supplement some extra, and it can really be a big game changer. And I know it can be a hard thing for families to think about and talk about. But that's why it's so important to have providers like you all on the care team. And I think that's actually probably a really good segue into our next speaker, who is Kira Berggren, who is a speech language pathologist from VCU. So Kira, I'm just going to go ahead and toss it right over to you.
Awesome, thank you. That was a perfect segue from both of you, actually, Dr. Fawcett and Dr. Williams. Thank you. So yeah, I'm Kiera Berggren. I'm a speech language pathologist at VCU Health. I've been working in MDA clinics in neuromuscular disease for the past 8 years, both pediatrics and adults, and I'm really passionate about the swallowing piece of things. So next slide, please. So today we'll talk a little bit about what is dysphagia, and then where does Duchenne and dysphagia kind of overlap, and then how can an SLP help? So next slide, please. And I promise I will not quiz you on the, well, maybe that pop quiz. But dysphagia just means basically abnormal swallowing or swallowing difficulties. And when I think of swallowing, I think of multiple things. And Dr. Williams, I really appreciate your nod to actually getting the food to the mouth as well, because that's a big piece for sure. But I look at, once we get it in the mouth, does it stay in the mouth? Are we able to move it around with our tongue in the oral preparatory phase, move it underneath the teeth, chew it up, all of that kind of stuff? And then the swallowing phases. So there's 3 phases with that. The oral phase, it's still in the mouth, and we want to move it back into the back of the throat area. Respiration and swallowing are really intimately linked too. And so when food moves back into the back of the throat area, we want to make sure, our body wants to make sure that we're not getting it into our airway. So we have to kind of protect our airway in the pharyngeal phase, or the kind of throat phase of all of this, until it moves down into the esophagus. So next slide, please. So how does Duchenne in particular affect swallowing? Some of the newer literature out there is showing that as individuals with Duchenne age, the strength of their tongue decreases. They may have some changes in the morphology of their dentition. I've had some individuals where they may have more of an overbite or an underbite as well too, so there can be some jaw issues. And the opening of the esophagus, at rest, our esophagus is normally closed up really tight so we don't get air in our tummy and burping all day long, and air goes into our lungs. But as individuals with Duchenne age, that opening may not have as much pressure, it may not be as tonic. So and then reduced hyalolaryngeal elevation, one of the mechanisms of protecting our airway has to do with our voice box area moving and kind of getting itself up and out of the way of the food passing past. And that elevation of that voice box area decreases in amplitude as individuals age. And then decreased respiratory function from a variety of factors. But as I mentioned, respiration and swallowing are really intimately related. And so if respiration function is decreasing, then it can impact that swallow piece as well too. So next slide, please. What we in patient reports from individuals with Duchenne, many of them will report what we call kind of pain while they're swallowing, or feeling as if food is stuck in the throat. I have individuals, oftentimes I see in clinic, that will tell me, there's a lot more saliva, that I have difficulty swallowing. There may be more coughing during meals or after meals. The meal times take longer. I like to always tell people kind of average in our country is about 20 minutes plus or minus for meal times. And when we start getting individuals in that 45-minute, 60-minute, hour and a half, 2 hours, I'm eating all day, that's an area where we kind of want to sit down and chat. So some individuals may have a decreased appetite, and there may be some unintentional weight loss with that. And as that respiratory function changes, we may see more respiratory infections, more frequency of choking episodes. So these are all things that we're looking at sort of clinically. And I'm really fortunate in the clinics that I'm in to have a dietitian there that I work very closely with as well too. So it's a nice kind of 1-2. Next slide, please. So how does speech pathology help with all of this? Our goal really is to work with an individual and identify what are their specific concerns. It's not really for any of us on the care team to tell you how you need to do things, but really kind of walk you through things, provide some education. There may be, we may recommend a swallow assessment. And I always like to tell people these are really not pass-fail, but really meant for us to get into the nitty gritty and see is somebody doing well, what are some areas that are of concern, and maybe are there some strategies that we can use to make people a little bit safer when they're eating. I really like to push the oral hygiene. Both the dietitians that I work with chuckle at me as I'm always asking people, how often do you brush your teeth? And even if somebody is not eating by mouth, we really want to make sure that the bacteria is not building up in the mouth and potentially being aspirated into the lungs and making us sick. So I tell people I'm not a dentist, but I do follow the ADA recommendations of brushing twice a day, cleaning between teeth. I'm not so good at limiting the sugary snacks, but we try and visiting a dentist a couple of times a year. So next slide, please. And then really sitting down with an individual after we've done the swallow assessment, looked at specific strengths and areas of support needed, looking at what are the goals of nutrition. For most of our patients, they would tell me, young patients and older patients that I see, that eating is really a quality of life kind of activity. And do we want to include a feeding tube in there for support? And I think all of us on the panel here are on the same page of that it's a supportive tool. It doesn't mean you can't still eat by mouth, for sure. And I tell people, eat the fun stuff by mouth and do the bulk of the nutrition through the feeding tube if you choose to. I'll also chat with a person about, with taking into account those personal goals and abilities, maybe some adaptive strategies, using one-way drinking straws or just using straws in general if it's hard to get the hand to the mouth for using a cup. Maybe using a nosy cup, maybe having better support or positioning of the body in the trunk and the arms to help support somebody if they're still self-feeding, or even just making sure they're in a good position to be safe and swallowing as best as possible. Of course, consulting with the dietitian and making sure we get good support on the nutritional side of things. And then also consulting with OT, if there's one in the multidisciplinary clinic, and certainly PT as well, for that physical support, especially if there's a lot of scoliosis or anything like that. How can we best position somebody? And then again, my bias as well to really support that oral hygiene. So next slide, please. So some kind of general tips for safe swallowing that I think about with all of my patients is making sure they're upright at 90 degrees. As I mentioned, having that trunk supported. Smaller bites and sips and single bites and sips tend to be safer, and maybe taking a bite of food and then a sip of water or some other liquid to help kind of wash down the food and moisten it a little bit. As I mentioned, straws can be good for head positioning for when we're swallowing to maximize safety with that. So next slide, please. Limiting distractions. This is a tough one. We're social creatures, especially in the evening. We want to catch up on the day, but really try to listen to your mom and not talk with food in your mouth. And think about moistening some of those drier foods. I'm with you, Dr. Fawcett, making sure that there's not one person eating one thing and everybody else is eating everything else. It doesn't have to be like that. We all eat the same things, and maybe we just have a softer meal later in the day as we're more fatigued. Taking medications, pills, vitamins in a little bit of puree, we naturally swallow stronger the thicker something is. And so that can make it a little bit safer. Or certainly if we have a feeding tube in place, that can be a really nice alternative and safer. And if you're at the table with somebody and you can see that they maybe have some additional food still in their mouth and they're getting ready to take the next bite, encouraging them to swallow one more time or maybe a couple of times to get that residue out. And next slide. I will also encourage my patients and their families to maybe have smaller, more frequent meals. So instead of trying to really get all those calories in at a single setting, breaking it up a little bit. We tell our little babies to really only go for 15, 20 minutes when feeding. And I think with neuromuscular diseases, that's actually a really good kind of goal as well to say, we don't want the muscles of speech and swallow to fatigue during the meal and put us at risk. So I'll also encourage people to what I call stage meals, or maybe if it's your birthday and you want to have steak and baked potato and a salad and something like that. Those are more complex food items. So really having them earlier in the day when we have more energy, those muscles are less fatigued. And then again, softer foods, so slow cooker items, casseroles, pressure cookers, that kind of stuff are generally going to be softer and easier. And I think we've seen some great advances over the years as well in terms of, it doesn't have to be just a puree diet. We can get really creative, and all the nutritionists I've ever worked with are just a wealth of knowledge. So please tap into them as well too. So, and really our goal for all of us here is really to manage the situation, to really make sure we're maximizing safety when you're eating, so that we're not getting stuff down the lungs and potentially causing other health concerns as well. So, and I believe that's it on my side. Next slide. Just had some quick references, but I will turn it back to you guys at the studio.
Fantastic. Thank you so much, Kira. That was really helpful information. And I think that between the three of you, we've really covered the lifespan of Duchenne. And I know that problems are very different for somebody who's 4 versus somebody who's 34. And so, I think that you each really spoke to those different phases in life. So I've got a few questions that have been submitted from viewers in the audience, and I'll go ahead and just start working through some of those with you all. So I think we'll start with you, Kandan. So the question is about the role of probiotics in health and digestion. So can you talk about what that role is for probiotics, particularly how it addresses or how it can be used throughout the lifespan? So what does that look like for somebody who's maybe in childhood versus adulthood?
Absolutely. And I think, maybe Dr. Williams might want to chime in on this a little bit as well. Probiotic is definitely a good way to go, to regulate that gut health and to try to keep us as healthy and regular as possible. I always like to try to encourage people to try food items and real foods before they go just directly to a supplement or a pill or something like that. Looking at something like yogurt that would have some good probiotics to help you naturally versus, having to take a supplement. And Dr. Williams, what else would you like to add to that?
Yeah, I would say a couple of things. One is I would like to even be more natural than trying to use a supplement that people think is like trying to reset and give natural bacteria. Because the next point I'd like to say is we really don't know what natural bacteria are. I mean, we don't really have a standard of what is normal. When we do studies, and I've been involved in some studies looking at microbiome and stuff, you always have to get a control group of kids with similar behaviors and patterns, which is tough to do. So we don't really understand truly what the standards are. Now, so with that being said, I mean, I'm not opposed to using probiotics, but there's no data out there saying this probiotic is great, this probiotic works, or anything like that. If a probiotic works for you, it works for you. I'm not going to deny that at all. But there's no real strong data out there of saying what probiotics should be and what should be in them.
That's so helpful, Dr. Williams. And it's actually, I had the exact same conversation with a family this morning as we talk through, what vitamins and supplements should I give my son? What's going to help him? And we really talked about, try to have that variety in his diet, that he's getting all of those different nutrients so that you don't have to look to, additional supplementation if you can. So this next question is for Kent. So Dr. Williams, I'm an adult and I don't really like to drink because then I have to pee, and that's just complicated when I'm out and about in public. So could you speak to, is drinking all day long really that important? How does that impact my GI health?
Well, it not only impacts your GI health, because you really kind of need to have the fluids to be able to keep your stools soft enough to come out, but also going to affect your circulatory system, your kidneys, even your breathing, because if your secretions get thick, if you're dehydrated, it's going to make it difficult to breathe at times. I got to give a shout out to Dr. Shell here, who I'm sure will appreciate that I actually include something from the pulmonary system in this conversation. So drinking is important. This is where I think working with a dietitian is very important, because doctors, we're great at managing fluids through an IV. You know, we're not so great when it comes to like what food you're eating and things like that. So I think working with a dietitian is really important in this situation. Like, what's the minimum you need? Because I think I do get it. I don't want you having to worry about going to the bathroom to urinate also and things like that. So it's very important, and I would work with a dietitian to make sure you're at least meeting the minimum requirement to keep not just your bowel regimen going healthy, but also the whole body, because it affects everything. In fact, there's lots of studies on dehydration that shows that it affects your concentration, your sleep, and other things too.
Thanks so much, Dr. Williams. I'll even add, if getting enough water in you is something that's difficult, I would even encourage our older guys to work with your PT or your OT. There are some really, really cool modifications that they can make to power chairs so that you've got easy and convenient access to stay hydrated all day long.
And
so
actually,
this next...
can I just add one more thing? This is the time, if you're having difficulty drinking, I would definitely think about a G-tube, because it's so much easier to give a bolus through a G-tube than to be worried and scared about whether you're going to choke and aspirate on it. It's very simple, and it just makes life so much easier.
Kiera, do you want to add to that at all? I think that's probably right up your alley.
It is, and I think that we can all weigh in on this one. Clearly, that hydration piece is super important for the whole system. And I would also actually put a nod out to PT and OT as well to help, because what we see a lot of times in the clinics I'm in is people self-dehydrate because they don't want to transfer, or they don't want to be a burden if they're out and about, that kind of stuff. And so there are a lot of options out there, and they can certainly help with that. But yeah, doing a swallow assessment is pretty critical too.
And I wanted to just chime in really quickly on that as well. I think, and part of what I do is the behavioral component. And I think just normalizing that this is what we do. This is how we do it. For instance, like when we travel with Tyler in the car, we have a urinal because he doesn't get out of the car every time we go. And you know what? That's just normal for us. And if somebody has something to say about it, we explain to them what's going on. But just being able to just advocate for yourself and explain, and especially when these boys are younger, helping them and teaching them how to talk to their friends or their peers about, I just do things a little differently. This is how I do it. How do you do it? Like, this is what I do. So I think just being able to kind of just normalize it, like Dr. Williams was talking about, everybody poops. Let's just talk about it.
Everybody poops. I think that's a children's book, right? No, I appreciate the candid conversation, particularly around G-tubes, because I think that topic in particular is just really hard to broach with families. That's a scary thing to think about if you haven't thought about it before. And it can be hard to start that conversation. But I think that, the one piece of feedback that we hear so frequently is, I wish I would have gotten my G-tube sooner, because it's just so incredibly life-changing. So this next question is for Kiera, and this is a really good one, particularly for families who maybe don't have a comprehensive coordinated clinic, and that is, where does one go to find a speech-language pathologist? I haven't seen one in clinic.
That is a great question. Unfortunately, we're not in every clinic just yet. We're getting there. But I would actually recommend that you talk with the neurologist that you're working with for referral, or even your primary care physician as well for on that. There's certainly ones in the schools, kind of a niche area. And so I'd really encourage you to turn towards the medical side of things and ask your physicians for support.
Awesome. Thanks so much, Kiera. All right. So this next question is for Kandan, and it does go back to supplements, but I think that this is a good one, particularly as it relates to bone health. So what recommendations do you have for calcium and for vitamin D? What are optimal levels and how much is too much?
Okay, well, and I will not specifically say, because I am not a dietitian yet, so I can give you recommendations on where to go and things like that. But what I would say is talking with your physicians about that. I know a lot of multidisciplinary clinics are prescribing vitamin D for bone health specifically. And that was one of the things that we talk about, is making sure that we're getting optimal calcium levels as well. And I will talk a little bit more on the food side, and I don't know if this is normal for most people in clinic, but it seems like our boys don't really like milk. Nobody likes to drink milk anymore. So really trying to focus on getting that calcium with that vitamin D level.
Great. Thanks so much. Yeah, I think that having that dietitian as part of that multidisciplinary team is so important, because they can work with you and your child, or you as an adult with Duchenne or Becker, specifically and directly, and figure out what your body needs, where you are, where you need to make adjustments. Kent, would you add anything to that? You're muted.
There we go. Sorry about that. I was actually looking up the dosing because we use it a lot. Kind of 2,000 units daily for vitamin D is kind of what people a lot of times will kind of give if you are low in vitamin D. Or you can give, sometimes they'll do like 50,000 units a week for that for a while. And then, as we said earlier, you really need to think about trying to get the calcium in also along with it. Sometimes we'll prescribe tablets of, of the over-the-counter Maalox or Tums or things like that. They'll have calcium in it to go along with it also.
Awesome.
And I'll chime in really quick too. Thank you for mentioning the Tums and things like that. There are a lot of chewable forms of calcium, so you don't have to take the big calcium tablets that are kind of horse pills. So look around for gummy forms, liquid form, that kind of stuff that are going to be a little bit easier to swallow.
Absolutely. Absolutely. All right. It looks like we've got time for maybe one last question. This will be a question for Kiera. So the viewer said, I've seen some boys that tend to have large tongues. Does that impact their swallowing function? And is there anything that we can do to prevent that?
I do see that as well clinically, that some individuals seem to have kind of a larger tongue in Duchenne. And I don't know that there's any study specifically documenting that impacts that swallow function. I kind of step back and alongside the dietitian sort of look at how has weight been. Have we been stable? And that tells us, or going up and staying on the growth curve, and that tells us, are we getting enough calories in? And then and I also look at, can we keep it in the mouth? I see a lot of individuals that maybe the food is coming out of the mouth because the tongue is maybe a little bit big. And so maybe we work with some individual strategies with that person as well from there.
Comes down to individualized care. It seems like that's just the theme, which isn't a surprise, right? Every single person with Duchenne is different and unique and has different needs. And we can look at natural history and what we know about progression, but every single guy has his own unique story. Every single girl has her own unique story. And that's why that coordinated, comprehensive, multidisciplinary care is just so, so important. Well, thank you, Dr. Fawcett, Dr. Williams, Kiera. This has been a fantastic conversation. I know I personally learned a lot, and I'm sure that everybody at home learned a lot too. So with that, we'll go ahead and close and send it back to Eric and Ryan in the studio. Thanks again, everyone.
Thank you, Rachel. And thank you, panelists. This was a really great discussion. We're going to spotlight some of PPMD's funded research now and some programs before we come back with our next panel on gene therapy. Be right back.
Hello, my name is Chet Villa, and I'm a pediatric cardiologist at Cincinnati Children's Hospital, and I specialize in heart failure and heart transplant. I'm also a member of the neuromuscular team here at Cincinnati Children's. I am co-leading a project with Dr. Linda Kripe at Nationwide Children's Hospital that is focused on understanding how centers are treating cardiac disease in Duchenne and what cardiac outcomes look like across North America. We are living in an exciting era where new therapies are keeping boys and young men stronger for longer. For us to continue to improve outcomes, we need to understand what the heart does as your boys become teenagers and teenagers become young men. In order to understand what happens to the heart in Duchenne over time, we are collecting data from CDCCs across the country and through a partnership with the Action Learning Network. Action is an international learning network focused on improving heart failure outcomes in children and young adults. Over 25 pediatric hospitals, including 8 CDCCs, have agreed to work collaboratively and share information about how each is treating boys and men with Duchenne and what cardiac outcomes look like right now. We will be collecting information like what medications people are on, how heart function changes over time, and what happens if the heart does begin to fail. But that's just the first step. Collecting information alone is not enough. We have to feed back the knowledge we gain to the community and to care providers so that we can improve outcomes rapidly in real time. For the community, having up-to-date information about heart-related outcomes will allow patients and families to use the most up-to-date studies to make the best decisions about their own care. And for care providers, the information will help understand what each center does best and how every center can adopt these practices quickly and effectively. No center is perfect at everything, but if we understand what each center does best, we can all get better together. With the help of PPMD, we're looking forward to advancing cardiac care in the current era.
Hey guys, we're the Kate family, and we've been involved in the Race to End Duchenne program for 7 years. Now, Race to End Duchenne is PPMD's signature endurance fundraising program, and it's a fun way to get involved and fight to end muscular dystrophy Duchenne.
From full marathons to 5Ks, there's a distance race for everyone, even for people that don't run like us. They even have bike races too. PPMD has added a virtual race so you can participate in races without ever leaving your neighborhood. We've participated in several races with the Race to End Duchenne team, and we've always had a great time doing it. For us, being a part of the Race to End Duchenne team means meeting new family members.
And fundraising.
And having fun.
Mm-hmm.
To find a list of races and join the Race to End Duchenne, visit www.racetoendduchenne.org.
All right, now join us.
Welcome back. Our next session is part of our In the Pipeline series, and this one's on gene therapy. To give us a quick refresher on gene therapy, here once again is Dr. Mena Scavina.
The root cause of Duchenne is a variant or change in the DMD gene that prevents the production of the dystrophin protein. The absence of this protein leads to a disrupted and weak membrane that surrounds muscle cells. One strategy to correct this lack of dystrophin is to deliver a replacement gene to the muscle cells that can function in place of the missing dystrophin. This is called gene therapy. The dystrophin gene is large. Current gene therapy clinical trials in Duchenne are exploring the use of microdystrophins. The microdystrophins are smaller genes than the full-size dystrophin gene. They are based on dystrophin changes seen in patients with milder cases. The hope is that these microdystrophins can act as a replacement for the missing full-size dystrophin and produce the protein that is missing. To understand gene therapy, we need to look at the 3 main components used to deliver the therapy. First, there is the transgene. This is the instruction for the body to produce a protein. In the case of current Duchenne gene therapy trials, different microdystrophin transgenes are being delivered. Second, there is a promoter sequence. This is a piece of DNA that tells the body where to turn on production of the transgene. The gene can get into many different tissues, not just the muscle, so we want to ensure the new protein is only produced in tissues where there would be a benefit, such as the skeletal or cardiac muscle. Third, there is the vector, which acts as the transporter for the transgene and the promoter to get into the target tissue. In current studies, a modified virus called adeno-associated virus, or AAV, is used. The AAV is a tiny virus with a limited storage capacity, which is why current studies use a microdystrophin transgene rather than full-length dystrophin instructions. There are different serotypes or versions of the virus, such as AAV8, AAV9, and AAVRH74, that are being used in trials. AAV does exist in nature, though it has not been found to be disease-causing in humans. However, because it does exist in nature, it is possible for an individual to have been exposed to AAV and for their immune system to produce antibodies to prevent infection. If an individual has been previously exposed to AAV, they may make antibodies that would prevent the gene therapy from being delivered to their muscle. This could make them ineligible for a trial. The formation of antibodies is also why redosing, receiving a second dose of gene therapy, is currently not feasible. Once someone has been exposed to a high dose of virus at the time of treatment, the immune system will work to produce antibodies to protect them from future infections. Researchers, clinicians, sponsors, and PPMD all recognize this is one of the biggest challenges to ensuring that all individuals can receive gene therapy and be redosed if needed. Many individuals and groups are working to overcome this challenge.
All right, and joining us today for our live panel, we have Luis Rodino-Claypeck from Sarepta Therapeutics, Carl Morris from Solid Biosciences, and Beth Beluccio from Pfizer. As a reminder, we will have a live Q&A after the panelists speak, so if you have any questions, please submit them to the comment box below. So to start the session, we will first hear from Sarepta. So thanks for joining us, Luis. I'm going to hand it over to you.
Great, thank you. Thank you for giving us the opportunity to present today. So thank you to all of the families who are also taking the time to listen, and we're happy to give you an update on our SRP-9001 microdystrophin gene therapy program. If I could have the next slide. This is just a reminder that we'll be making a number of forward-looking statements during this presentation, and these include risks and uncertainties. Please feel free, I'm not going to read this to you, but visit our website to read this in detail. Next slide. In our ongoing SRP-9001 clinical trials, we've now treated over 60 patients, and we have follow-up for some of them past 3 years. So in totality, we have 3 trials. Trial 101 was the first trial, open label trial in 4 patients. This was started with Dr. Jerry Mandel at Nationwide Children's Hospital, and now patients have been followed for 3 years in that study using clinical manufacturing material. Next is trial 102. This is a placebo-controlled trial in 41 patients, where in the first year, half of the patients were treated with SRP-9001 and half received placebo. Now we're in year 2, where the patients that received placebo have now crossed over. And so we're still following the patients in the year 2 of the trial. And now finally, which we'll talk about in more detail today, is trial 103. And this is our first trial using commercially representative processed material. And in totality, we have approximately 32 patients planned for this study. And I'll give you more details in the next slide. I could have the next slide, please. Thank you. So this 103 study is called our Endeavor study. As I mentioned, this is an early stage phase 1B study that's really focused on examining safety and microdystrophin expression of our commercial processed material, or SRP-9001. It's open label, there's no placebo-controlled group. There's no mutations excluded in this trial, and it's based in the United States. So we've started, there are 3 cohorts. Cohort 1 was our first cohort in 20 patients who are ambulatory between the ages of 4 to 7. We've recently added 2 additional cohorts. Cohort 2 has approximately 6 patients who are ambulatory and between the ages of 8 to 18, so older ambulatory patients. Also, cohort 3 is approximately 6 patients who are non-ambulatory with no upper age limit. Importantly, both these cohorts will not require a minimum washout period from other treatments designed to increase dystrophin expression, but patients will have to stop those treatments prior to the study. As you will see, these cohorts are very small with approximately 6 patients in each cohort. The primary endpoint for the study in totality is microdystrophin gene expression from baseline to week 12 as measured by Western blot. Next slide. So we previously shared data from our first 11 patients so far, and we shared this with on a PPMD presentation as well. What we found is that safety has been consistent with our previous experience from our clinical material with SRP-9001. In total, we've had 79 treatment adverse events in the first 11 patients, with the most common adverse event being vomiting, which typically occurs in the first week, which is mild and treated with standard medications. We also continue to see increase in liver enzymes that are transient and responsive to steroids, with no signs of impaired liver function. We had SAEs in 2 of the 11 patients that have fully resolved. 1 patient with increased transaminases or liver enzymes who was treated with intravenous steroids, and another patient with nausea and vomiting, and no clinically relevant complement. Next slide. Now, in terms of the biopsies, in our first 11 patients, we performed biopsies at baseline and at 12 weeks in the gastrocnemius muscle. And so, as we've shown previously, we analyzed the biopsies in multiple ways. First, asking the question, did the transgene get to the muscle cells? And so we saw a mean of 3.87 vector genome copies per nucleus across the 11 patients. Next is the protein being made. Are we seeing sufficient quantities of microdystrophin? And indeed, we're seeing 55.4% microdystrophin as compared to normal, mean compared to normal. Then we also ask, is microdystrophin getting to the right place, and how much is getting there? We do this by staining the muscle biopsies using immunofluorescence staining, and then we quantify this in 2 ways. One, looking at the total number of positive fibers, where we see 70.5% in the 11 patients, and then also in the intensity compared to normal. So we see 116.9% as compared to normal at 12 weeks. Next slide, please. So in terms of our clinical development, we now have 2 trials using clinical material from Nationwide Children's Hospital. That was trial 101 and 102. Our first 2 trials were in the ages of 4 to 7. We're now following patients in the 102 trial during year 2, and we expect to complete part 2 of the study by the end of this year. We're currently, as I just described, in the midst of trial 103, where we have a total of 32 patients planned across 3 different groups, 4 to 7, older ambulatory patients between 8 and 18, and cohort 3, which is non-ambulatory with no age limit. And then we're leveraging all of the data to inform our next studies using our commercial process material, which will be studies 301 and 303, which will both be double-blind placebo-controlled. Next slide. So just to summarize where we are in our development, we've treated over 60 patients with follow-up for 3 years for some of those patients, and we continue our commitment to build a strong foundational knowledge of microdystrophin gene therapy. In terms of immediate next steps, we're going to continue to advance part 2, study 102. This is the crossover phase, and study 103, which is our open label study using commercial process material. We've expanded study 103 to include 2 cohorts. That's patients that are non-ambulatory as well as older ambulatory patients. And we're continuing to do in-depth analysis on all of this using our current data available. In terms of our future clinical development, we're very committed to starting our next study, which is study 301, or our EMBARK study. And our immediate next step for that is to meet with the FDA, and we hope this will occur in the middle of this year. We're using all of our data, including 102 data, to inform the design for that study, and we'll be able to communicate with the community as soon as we meet with the FDA and have more information available on that study. And so just to close out, I'd like to thank all of the participants in our trials, families, the clinicians, and the site staff who are participating in our studies. And I'll be happy to take questions now and at the end. Thank you very much.
One brief follow-up question before we move on to the next panelist. PPMD was proud to fund the original study you termed 101 with nationwide of those 4 patients. And these patients, 4 patients, are patients that have been on gene therapy longer than any in the U.S. I'm just curious about how long you're going to be following them and how you're going to be measuring durability with these patients. Is it functional or measuring microdystrophin?
Yeah, great question. So the last data that we showed was at 2 years in the fall, and what we saw was durability in terms of functional improvement. So we saw continued functional gains from baseline, and that were consistent across time. So we're going to continue to follow them as part of the protocol for 3 years, and then an additional 2 years, so a total of 5 years. But as you know, we'll be continuing to follow these patients for quite some time and measuring their function over time.
Okay.
In the 102 study, we are measuring durability by having multiple biopsies. And so that study will be ending this year.
Okay, great. And great to see studies expanding into older. Okay, our next panelist is Beth Beluccio from Pfizer. Beth, I'm going to hand it over to you.
Okay, thank you. Actually, those are Carl's slides, so maybe I'll give it back to Carl.
So hi, I'm Kyle Morris. I'm the CSO here at Solid Biosciences. First, I want to thank the PPMD for the opportunity to talk through our nope. All right, they're going back to you, Beth.
Okay. Yeah, okay, that's fine. I'll go. This is like musical chairs a little bit. All right, so hey everybody, I'm Beth Beluccio. I'm the Global Clinical Lead for Rare Neurological Diseases at Pfizer, and hope everybody's ready for summer and enjoying this great conference. Really appreciate a chance to talk to you guys about our gene therapy program for Duchenne muscular dystrophy. Next slide. Right, so this also, we have a disclosure slide. But we can go on to the next one. So what I want to share with you today is an update on our set of studies to evaluate gene therapy for the treatment of Duchenne. Our therapy now has a new generic name. It's long, fortadistrogene movaparvovec, quite a mouthful. So from now on, I'll just call it by fortadistrogene. We do have 4 separate studies that will evaluate this therapy in Duchenne. We have our ongoing phase 1b study that now includes both ambulatory and non-ambulatory participants. We have an ongoing phase 3 CIFRIO study for the evaluation of ambulatory boys between the ages of 4 and 8. And then we have 2 planned studies, a phase 2 study for early symptomatic kids between the ages of 2 and 4, and a planned phase 3 study for non-ambulatory participants for which there's no age restriction. So during this presentation, I'm going to give you a brief update on each of these studies. Next slide. So starting with our ongoing phase 1b study, as you know, we started it in the ambulatory population, and we've now treated 19 participants. The age of the included participants so far has been between the ages of 6 and 12 with a median of 8 years old. We'll next update the community on data from this population once they've all completed 1 year since dosing. Now we've also opened the study to non-ambulatory participants, and we took this step because we felt it was really important to begin evaluating safety and efficacy in older and bigger people with Duchenne. Ultimately, of course, our goal is to collect the information necessary to get this therapy approved and available for the entire population. So far we've treated 2 non-ambulatory participants in the cohort. One of them did experience a complement-mediated SAE that was very similar to what we've seen and reported in our earlier in our ambulatory population. So I want to emphasize about this that at Pfizer, we're really dedicated to the safety and well-being of these participants. And one thing that's clear about the studies is that we've already learned a great deal about what to look for these patients and how to manage the signs of complement-mediated immune response. So in this non-ambulatory participant, we were able to catch the signs early, and with treatment, he made a full recovery. So then I wanted to tell you also about a new cohort that we're about to open. This is because we're interested in evaluating sirolimus in conjunction with gene therapy. Sirolimus is a well-known medicine, and it may be an additional way to reduce the immune response to the AAV vector. You know, in Duchenne patients, we're all familiar with using steroids to inhibit inflammation. And what we want to do is understand if sirolimus could be an added tool to manage immune reactions. Sirolimus is also being evaluated by other companies in the setting of gene therapy for other disorders. So this is sort of an interest across the field. We will continue enrolling our non-ambulatory participants into this cohort as soon as our protocol amendment is approved, which we expect to be in the very near future. So what's really important about our experience so far in our phase 1 study is our data continue to support our chosen dose, and that also we have a really good process for monitoring and addressing any issues that may arise. So now I would like to turn to our phase 3 study in the next slide. So this is our CIFRIO study in the ambulatory Duchenne population, and you probably know that we had our first patient dosed last December. We continue to open sites around the globe. We now have 20 sites enrolling across 9 different countries, as shown in the map. Unfortunately, we don't have sites yet open in the US, and I know this is extremely frustrating to our families here. And so what I wanted to tell you is that we are working very hard at Pfizer to address the FDA requests, and we are poised to open our US sites as soon as we get the green light from the FDA. At this time, I can't tell you exactly when that will be, but I can promise you that we are doing absolutely everything we can to meet their requests. Now I want to tell you a little bit more about our 2 planned studies. So then in the next slide, describes our phase 3 global randomized double-blind placebo-controlled study in the non-ambulatory population. Similar to our CIFRIO study, we have a provision that all participants will be eligible for gene therapy, including those who are initially randomized to placebo. And also similar to all of our studies, we follow all participants for 5 years after they receive their gene therapy. Now, in this study, the inclusion-exclusion criteria will not have any age limits, but we will ask patients to meet some functional requirements, in part to protect patient safety while they're in the trial. Our primary endpoint will be the Performance of Upper Limb 2.0 total score, and we'll also very carefully assess both pulmonary and cardiac function. The full details of the study design will be available on ct.gov as soon as we get closer to starting the study. Next slide. And I also wanted to tell you about our phase 2 study in children between the ages of 2 and 4 with Duchenne. So this will also be a global study and include sites within the US. It will be a single arm study, meaning no placebo arm, and it will be primarily focused on safety. We will also evaluate, of course, efficacy in this age group, but endpoints for younger children are not established or validated, so we call them exploratory. We also will include muscle biopsies in this study to make sure that the mini-dystrophin expression is the same in this age group as we've seen in the older kids. And similar to our other studies, we'll follow all these kids for 5 years after they receive their gene therapy. Next slide. So just to conclude, I've told you that our phase 1 study is ongoing and currently focused on enrolling non-ambulatory participants, with a new cohort soon to open for the assessment of sirolimus, and that our data continue to be very encouraging. We have good processes in place to maintain patient safety. Then our phase 3 CIFRIO study is enrolling with 9 countries open and more sites opening every week. And then we have 2 planned studies to evaluate our fortidistogene in the non-ambulatory population and in children between the ages of 2 and 4. Next slide. So with that, I'll just end by thanking PPMD for this opportunity to talk about our program, and also for their fantastic collaboration and support over the years. Also acknowledging the wonderful community of advocacy groups that we work closely with. And finally, I just want to emphasize that we also are very grateful to study participants and their families who are willing to take on the very hard work and stress of being involved in these clinical trials. We are really, truly appreciative to all of them. Thanks, and I'll take any questions.
Thank you so much, Beth. I'm going to just do a brief question and apologize to you and Carl for the quick switch and to the control room. So,
no problem.
So with the study that's enrolling now, both outside the U.S. and eventually in the U.S., could you explain competitive enrollment, and is there a possibility that the trial could fully recruit before this actually gets to the U.S. to recruit patients?
Right. So competitive enrollment really means that it's our intent to try and gather the data as quickly and as efficiently as we can, so that then we can be able to provide that to regulators. Because as everybody knows, ultimately the way you serve the entire community is by getting the drug approved. So we are trying to enroll as quickly as we can. And although we hope that we are going to be able to get US participants in the study, there is a possibility, depending on the FDA response, that we will fully enroll before we get to that point. So that's why we're working so hard and diligently with the FDA to make sure that we can get the go-ahead as soon as possible.
Thank you. I appreciate that answer. Okay, we're going to change now to Carl this time. Carl Morris from Solid Biosciences. The floor is yours.
Great, thank you. Hey there, everyone. Yeah, so I'm Carl Morris, Chief Scientific Officer here at Solid Biosciences. Just want to thank PPMD really for the opportunity to present to the community about our AAV microdystrophin gene therapy program, which we call SGT-001, and our ongoing clinical trial, which we describe as IGNITE DMD. Next slide, please. Not to make too much of a hullabaloo about everything, but as a public company, we have to share these slides, and please note our forward-looking statements here and on our website. Next slide. Yeah, so as many of you are aware, Solid was founded by parents directly impacted by Duchenne. So patients are really at the forefront of what we are trying to do. We really have engaged in the community, with the community, and truly value the input from everything from designing our clinical studies to providing meaningful insights into to further our understanding of the disease progression. Duchenne is a disease that really requires multiple perspectives to affect long-term changes and really to support development of potential treatments for this disease. So we work closely with people outside our walls to collaborate and identify ways to really drive our core mission in Duchenne. Internally, we've built a good team with vast experience in muscle biology, gene therapy, clinical and regulatory experience, as well as a patient advocacy that allows us to really sort of help develop those treatments for musculoskeletal diseases. And importantly, given the data that we've seen, the durable and so long-term data that we're seeing from SGT-001 really sort of supports the continued advancement of our clinical pipeline. Next slide. Over the past 6 months or so, we sort of announced the addition of two programs that provide sort of alternative approaches to deliver our microdystrophin gene therapy to patients with Duchenne. All three of these approaches use our differentiated nNOS binding domain containing microdystrophin, but each use capsids that may provide more opportunities for more patients to receive the payload effectively. For SGT-001, it's in our ongoing clinical trial, which I'll sort of talk to mostly in the next couple of slides. SGT-003 uses a next-gen, rationally designed capsid that enables us to express about 3 times more microdystrophin in the muscles of MDX mice at a similar dose to that of AAV9, which is our current capsid. So what we're hoping is that this will provide an opportunity and to have greater potency in delivery of our capsid transgene. And finally, the partnership with Ultragenyx is sort of also enabling the use of an AAV8 variant and really a different manufacturing platform to help support getting the drug to as many patients as possible, as soon as possible. both of these programs, the 003 and the Ultragenics programs, are quite early on in development, but we hope to, we at SOL will hopefully update on the 003 program when possible, and also Ultragenics will sort of begin communicating when appropriate. Next slide. So just to sort of set what we're doing in Ignite DMD. So currently, really our focus is on ambulant patients 4 to 11 years of age, although our first patient was a non-ambulatory 14-year-old, and we hope to get back there as soon as possible. When we originally initiated Ignite DMD, it was designed to be a randomized controlled ascending dose trial, and we subsequently modified it to an open label, non-randomized design when we transitioned into the high dose cohort. Today, 3 patients were enrolled at the low dose, 5 at the high dose, and a total of 3 patients were analyzed as part of the control cohort. The study population and entry criteria are listed here, and it's generally sort of a standard fare, antibody negative, and sort of a stable dose of corticosteroids is necessary. The primary endpoints for this study obviously is a phase 1/2, where with safety, as well as we looked at changes in microdystrophin expression in the muscle biopsies at 12 months as assessed by Western blot, and I'll talk about that in a bit. As we reported in March, we resumed enrollment in Ignite, and we've now dosed 2 additional patients under the amended clinical protocol and with a new manufacturing process that enhanced our full empty ratio up to 90% full. We previously also reported, and so patient 7 was dosed uneventfully, while patient 8 was found to have a systemic inflammatory response and classified as an SAE by the investigator. Happily, and the patient has fully recovered, and all the lab values are back to normal. We shared the data with the DSMB and FDA, and we're working closely with both to sort of move forward and get back into the clinic as soon as possible. Now to highlight some of the efficacy that we've sort of described. Next slide. Here, just showing one example of what we've observed. We were able to recently sort of take muscle biopsies in patients out to 24 months and then analyze them. And as you can see here in all 3 patients in the high dose cohort, that even out at the later time points, we're getting a good positive widespread distribution of microdystrophin positive fibers. And so out to 24 months in patient 4 and 12 months in patient 6. So and we're looking at levels of 10 to 30%, up to 85% positive fibers in these patients. Also, we did look at Western blot to get a more quantitative assessment, and at the later time points, patient 4 remained sort of at below the level of quantitation, which is 5%. However, there seemed to be an apparent increase in expression from about 20% in patient 5 up to 70% of normal, while patient 6 went from about 8% to 20% expression at the later time point. Next slide. So in March at the MDA clinic, we reported the long-term clinical biomarker and functional data is sort of highlighted here. As you can see on the heat map, there were positive trends in many of the endpoints in the dosed patients at that 1-year time point, with more green seen below, which is a positive response, seen at the bottom in the high dose cohort than that in the top in our control untreated group. The endpoints evaluated range from the creatine kinase, which is shown on the left, through several functional measures, North Star, 6-minute walk, and forced vital capacity, pulmonary respiratory measure, as well as looking at sort of an outcome measure, and all sort of trended in a really nice direction. For this 2E14, and at the time this was encouraging. Now with the promising long-term results that I just shared, it really sort of provides a mechanistic underpinning for what the apparent positive trends we're seeing here. Next slide. And so to summarize, just highlighting here some of the milestones and priorities for Solid at the beginning of the year. And really, we've accomplished 3 at present, as shown up top. So really, to get back in and resume dosing of patients, identify some of the long-term safety and efficacy results, as well as sort of expansion of the pipeline. Importantly, and coming up soon will be, sort of evaluation of the 90-day biopsies from these additional patients, as well as sort of a discussion about how to advance towards commercial readiness and the preparation for our registration trial. And next slide. And finally, I'd just like to again thank the community, the patients, as others have said. It's amazing how the community sort of has been getting behind us, and as we sort of work to look for treatments to patients with Duchenne. Thank you.
Great, thank you so much, Carl. Just a very quick question. We all know this is a heterogeneous population where age might not be the best inclusion criteria. Will you continue to recruit based on weight and function rather than age going forward?
So right now we took a cautious approach, and we were sort of reducing the weight for safety aspects and thinking about the total viral load. As we go forward, we will reconsider that and look about it, and maybe function, maybe age, as you I agree with you, is not the best representation of how we should be looking at this, right?
Great, thanks. Now Eric's going to start the panel discussion.
Yeah, we've had a lot of questions come in. Many of them can go to the whole panel, so we're going to probably rapid fire around a little bit as we go through some of these. Obviously, one of the big topics and concerns is about neutralizing antibodies, whether that's pre-existing and preventing families from being able to access therapies, or for those who have been dosed and preventing the redosing. And so I think families would really appreciate hearing how all of the companies are thinking about this. What are you doing in terms of preclinical research or partnerships with other companies in terms of exploring ways that we can get around this challenge? And so Beth, I think I'm going to just throw it to you first, and then we'll kind of go around.
Yeah, sure. Yeah, of course, it's a very important topic, and it's going to be important for all the science to advance so that everyone can have ultimately access to the therapies. At Pfizer, we do have several sort of approaches that we're exploring in terms of how to reduce the antibodies, either to allow for redosing or to allow those who have existing antibodies to be treated. I think what our feeling is that at this point it's too early to tell exactly which approach will work. So we do think it's important to kind of advance on multiple avenues of trying to achieve that. Those studies are still very early. None of them are really ready for the clinic, but we are working to get ready so that we can advance them all to the clinic as soon as possible.
Thank you. Louise, could you share a little bit about how Sarepta is thinking about this?
Sure. This is a great question and something that we're very much dedicated to, both treating patients that have pre-existing antibodies and then for redosing. And so we have internal efforts that we're working on with ways to physically remove antibodies using things like apheresis that we've been working on for quite some time. We also have partnerships with Hansa that would potentially reduce antibodies in patients with pre-existing antibodies, and then Select Biosciences at preventing antibodies and then potentially allow redosing. All of these are in preclinical studies in small and large animals, and we're moving them forward as fast as possible.
Great, thank you. And Carl?
Yeah, I mean, the same thing. We have a number of programs, and clearly this is a need, and we need to be able to dose as many patients as possible, regardless of seropositivity. And so, obviously, we're working hard, having an immunology team that's really focused and dedicated to identify either appropriate paths or partners to get this moving.
Great, thank you. And then another question. So you all have kind of different thresholds that you set for those antibody titers for when it's acceptable, in your eyes, to dose a patient. Can you maybe just talk a little bit about the evidence and the rationale used to come to what those thresholds are? Is this based on preclinical data? Is this learnings from other diseases? Carl, maybe I'll start with you. And go from there.
Yeah, I mean, some of it's based on preclinical work and looking at what thresholds allow for transduction to continue. You don't want to lose your efficacy while you're dosing. There's both the safety side and the efficacy side that we have to consider in terms of the antibody levels. There's also some safety. We did some preclinical work and talked to other people in the preclinical space to really think about where a threshold may be in terms of safety. And so we selected that based on as much data as we could. But it's still a TBD in many ways.
Great, thank you. Beth, Louise, if either of you have any additional comments, you can throw them in. If not, I can get another question going. All right. So this one actually for both Sarepta and Pfizer. So you're working with and kind of preparing some placebo-controlled trials, and that does raise a challenge of there is going to be a period of time when patients are enrolled, not able to receive gene therapy. Have you had discussions with regulators about kind of the ethical aspect of that and potential ability for someone to develop antibodies while they're kind of in that waiting period? And maybe Louise, since Sarepta has done a crossover study, maybe start with you.
No, it's a great question, and it's not something we take lightly, but we have had those discussions with regulators, and the advantages after 1 year, the patients do cross over, even though we're mindful that that is a year. We were grateful for the first 102 study where we did monitor patients and crossover. We did not see any patients seroconvert during that time that were unable to receive the therapy. So that was good to see, and I think it speaks to further work that needs to be done to make sure that we're being mindful about how seropositivity will, the chance of seropositivity or converting over a period of time. Sorry.
That's all right. Thanks.
Fumbling over my words.
Beth, can you maybe share as well if any conversations you have all had?
Yeah, we've talked a lot with regulators about this because we really wanted to, as much as possible, limit or even avoid, if possible, the exposing kids to placebo and making them wait. But the regulators were really quite insistent on having fully placebo-controlled trials. And I think one reason is when they get the data, they want to be able to make a definitive decision and feel confident in the data so that they can hopefully approve these therapies. So we've talked to them a little bit about how to help protect patients who are then having to wait for the crossover, and we've also worked a lot with our experts and our investigators on trying to minimize the risk for the patients in the study. So it's great to have sort of that community of people really thinking hard about, if you do have a placebo-controlled study, how you try and make sure that patients will be able ultimately to receive that delayed treatment.
Okay, thank you.
Great. Yeah, I have a question about, we're going to stick on this neutralizing antibodies question regarding the screening. So collectively, we're getting close to, I think, around 100 patients that have been dosed, but even more have been screened for gene therapy. Are you able to comment on the percentage of screen failures based on neutralizing antibodies? I'm going to start with you, Louise. Sure.
Now, as we did a study looking at pre-existing antibodies for RH74 vector across DMD and limb-girdle, and in DMD, it was 15 to 70%, and the screen-out rate actually in our trials was less than that. So that was across a broad population that was not destined for enrollment. So it's actually been a little bit less than that for our trials.
Okay, Beth.
Yeah, so one of the things that we're sort of interested in gathering the data, although at the moment it's sort of premature, is how these rates, if the rates differ from across different regions, and if so, if there's any explanation we can get for that. In our global study, it's still early days, so I don't think we can comment yet on that. But it is something that we're interested in. Sort of observing how consistent it is, or if there are regional differences in antibody levels.
Yeah, it's going to be important to publish on that. We're encouraging publication so we can learn from that. And Carl?
Yeah, I mean, again, similar to Beth, we use the same vector, and it depends on the stringency of the assays that you're using. But as reported preclinically, sort of the 30% level is sort of reasonable. 20 to 30% positive is sort of a reasonable idea of what's out there in the population.
Right. And as you are all starting to think and plan for studies where you're looking at older patients, non-ambulatory patients, where we may have heavier patients involved, can you kind of talk to us about how you're thinking about weight-based dosing? Is there a threshold, either of weight or virus, where you kind of won't go over in terms of delivery, just from a safety perspective? And Beth, I think as you guys are kind of planning for this.
Yeah, I'd say that. One thing that we don't really understand yet is if there are going to be any effects that are related to weight and the total viral dose. It's a good hypothesis that there may be, but we don't really know that yet. So the approach we're taking at Pfizer is to sort of be cautious about starting with lower weight kids and building our experience that way. And then also, as we do that, trying to collect as much information as we can about other aspects of the patients or their background or their disease state that may also influence their reaction. So we are thinking about the weight, but trying to collect a lot of data to better understand, how the therapy may play out in the older population.
Great, thank you. Louise?
It's similar. I think, one of the things that was so important to us about expanding our 103 study for older and non-ambulatory patients was to gain that safety experience prior to starting the phase 3 study. And we're taking an approach where we're incrementally going to higher weights to gain that safety experience. So I agree, it's a hypothesis, but so far, collective data we have also from our other limb-girdle programs using the same platform, we haven't seen a weight-related adverse events.
Great, thank you. And these last couple minutes, we'll do some specific ones. So, Carl, can you give us a little bit of insight in terms of, as you're developing this SGT-003, but a question about maybe timing, and is this something that, if ready for clinic, would kind of phase out SGT-001?
So it's really early. It's sort of and we have to go through the necessary steps in drug development to get us where we need to get. The goal is to, as quickly as possible, sort of identify some clinical proof of concept. And sort of once we have those data and better understand what it gives us and what it doesn't, we'll be able to make sort of really those types of decisions as to whether we're going to be, is it taking the place of SGT-001? Is it additional? Does it provide some other differentiated function that we're just not aware of yet?
Okay, great, thank you. Louise, could you possibly shed any light on the difference between that study 301 and 303 that you showed kind of at the end of your slides?
Sure, yeah, 301 will be more similar. We're waiting for feedback from FDA on a START 102 study in the 4 to 7 year old age range, and then the 303 will be older, non-ambulatory.
Okay. Great, thank you.
Mm-hmm.
And then the last question, Beth, can you give us any update on your progress with that potency assay with the FDA, and maybe just also a brief explanation of what that is for families who may not be aware of potency assays?
Right, so the FDA, of course, looks at lots of aspects of clinical development, and they look at our studies and how they're designed. And they also look at how we make the gene therapy compound, so the manufacturing process. And they have, every company, Pfizer, and I'm sure the other companies have a long list of tests that we put the compounds through before we give them to patients. Every single time it's manufactured, you run the compound through these tests. The potency assay matrix is just one of those tests. And the idea there is to make sure that the compound as it's manufactured will have approximately the same effect as another, that every vial will have approximately the same effect. So the FDA is working with the companies to make sure that the tests that we're using match what their specifications, and and so what we're doing is just working to try and meet the requests that the FDA has put into place in terms of what they want those tests to be. It's an ongoing conversation, and we're very engaged with them. We have confidence that we'll be able to meet their requests. So we're just working on that as quickly as we can.
Great, thank you. And thank you all for joining us today. We really appreciate you taking the time and discussing some of these questions. There's a lot more for us, obviously, to dig into, and I think this will create some good education opportunities in the future. So thank you all for joining us tonight.
Yeah, that's great. Thank you, everybody. And the good news is that many of these companies are going to be involved in our update to the Duchenne guidance. We're sort of going to force them to work together and talk through issues that could help as we develop gene therapies. So we're excited for that. So now we're going to hand it over to Pat Furlong. We are so lucky to be here today with Dr. Celia Witten, who's joining us. She's the Deputy Director at the FDA Center for Biologics Evaluation and Research. It's much easier to say CBER. This is the center at FDA that oversees gene therapies. We've known Dr. Witten for many years. We've had the pleasure of working with her, and I'm so grateful that she's here to talk with Pat. Pat, I'm going to hand it over to you now.
Thank you, Ryan, and welcome, Dr. Witten. Thank you so much for joining us tonight. We so appreciate your time.
Thank you.
Sure. I have loads of questions for you, Dr. Witten, in our short period of time. The first one is about CBER and CDER, the Center for Drugs and Center for Biologics. You know, our community is very familiar with CDER, the Center for Drugs, and now very hopeful for gene therapy, which sort of lands in your lap. Is there a crosstalk? How do you communicate and get all of the learnings that have occurred in the antisense oligonucleotides and the steroid approvals and take that into account as you look at gene therapies?
Thanks for that question. We're very excited about gene therapy in this area. I'll just say that. And I think our communication with CDER, who has more, more experience with approvals, is important. But we've had regular communication for years. So I'll describe some of the forms of communication. They are both programmatic and also in the setting of specific applications. So we have a monthly meeting that actually includes all three product centers, CDER, CDRH, and CBER, to discuss specific neurology applications and topics of shared interest. So those could include things like clinical issues, endpoints, trial designs, and also the rationale between specific regulatory decisions. So that is an important forum for communication, so we have regularly know what is up in each other's area and can have some discussion about it. And also consultation is obviously important. So when we review specific applications, we frequently consult other FDA centers. In this case, it would be the neurology group at CDER, and their perspective, expertise, and experience are often useful in our consideration of clinical issues like the interpretability and meaningfulness of proposed endpoints. And then there's some other efforts in terms of, development of tools for product use that I think are still in development. We don't really know, how they'll be used, but we certainly are interested in the, the CPATH efforts and the area of drug development qualification program. So we do learn about those and follow along and hope to benefit as those, tools evolve.
Yes, thank you. We had a call with Krista Vanderborn from Imaging DMD, and she's talking about the qualification process for fat fraction. So we're very interested in those tools. So Duchenne is a slowly progressing disease, as you know, and sometimes it's really hard, especially in short periods of time, to evaluate safety and efficacy. So I would love for you to comment on this accelerated approval pathway that we experienced in the Center for Drugs, and how you're thinking about that in gene therapies.
Yeah, so just, to take a step back and talk about just the overall context of accelerated approval. Mm-hmm. And I agree it's an important topic. Home runs are easy to assess. Of course, that's what we always want, would want, hope for. And if you have one in Duchenne's, for example, maybe you'd see the disease stop, the strength return to normal, a normal or a near normal biopsy. And that would take only maybe a clinical trial of a year or two to be confident. But home runs are easy to assess. But the challenge is that most products are not home runs, and the benefits may be more modest. The interpretability of the study then becomes more subjective and variable. So in these situations, just as a general matter, it becomes critical to have concurrent, controlled, appropriately blinded clinical trials, and longer duration studies become even more important to be confident that the effect is real. And I just caught the tail end of the previous discussion, so I know there was pretty active, comments on some of these points. But we support CBER as a center, certainly supports accelerated approval, and the office that regulates gene therapy for Duchenne's in particular used it recently in the approval of a CAR T-cell product in oncology. So it is part of what we do. Accelerated approval relies on a surrogate endpoint that's reasonably likely to predict a clinical benefit. And our ability to rely on such a surrogate depends on having a good understanding of the pathophysiology and natural history of the disease and the role of the proposed surrogate in that pathophysiology. So for many rare diseases, those may not be well understood. Fortunately, in Duchenne's, the pathophysiology is generally well understood. The role of dystrophin in that pathophysiology is well understood. In gene therapy applications, it should be noted that the sponsors have proposed to use many versions of dystrophin as a surrogate. And the role of mini-dystrophin in the pathophysiology of DMD is less clear than the role of dystrophin. I'm just mentioning that is one of the things that we would keep in mind. So in general, though, just getting back to the general topic, if a drug company proposes to use a specific endpoint as a surrogate for clinical benefit, we would ask them to submit data to support that the proposed surrogate is reasonably likely to predict a clinical benefit. So we're always open to this option, but we need to see data to support the proposal. So I guess that's right.
It's hard, right, because of the slow progression, and I do understand. And so as you look at, you're doing many, or you're overseeing many gene therapy, pediatric gene therapy studies. What are the ways you're thinking about to accelerate approvals or to accelerate this process? As you know, so many people are out there waiting and hoping for certainly a gene therapy that is both safe and effective. So how are you thinking about that?
Well, that is a really good question. And let me say that one of the things that we care about and always are thinking about are any efforts to develop cross-cutting tools. And something that might be useful in more than one setting, that is not in a specific sponsor's own development program, but across the board. And so one area, as you know, that is definitely of concern to FDA and the community and the patient community also. And again, I heard a couple of questions about this in the tail end of the last discussion, is the question about neutralizing antibodies and neutralizing antibody testing. And so that is, it's important. And it's important to understand what the results mean. And it's important both for the individual product, but it's important across the field to really, understand it so you can interpret things from one setting to another and really understand, the data more generally than just what the results meant for that setting. So we have, for that kind of thing, and for a number of other topics like that, a couple of years ago, FDA stood up a group, an organization. It's a public-private partnership called the Standards Coordinating Body. Mm-hmm. And that organization looks at opportunities for standards development in the field. This is one of the topics that they looked at. That group doesn't develop standards, but they support standards development by facilitating participation of U.S. experts in standards development efforts. So I'm hoping that this topic of neutralizing antibody it is proposed as one of the topics at an international standards organization to take up. And what that means is they would develop test methods that people could more uniformly apply for that kind of testing, so you could interpret it better across the field. And there's a lot of examples like that. So the standards world is one area where I think further work in standards can enhance the field. Then there's other questions like, how do you leverage information from one development program to another? And that could be the data about the vectors. It could be information about preclinical testing. I mean, it's a general question. So one of the things that CBER is doing is partnering with the Foundation for NIH NCAT and NCATS on the so-called Bespoke Gene Therapy Consortium, BGTC. And the objective of that group is to look in a consortium framework at a common set of procedures in a pre-competitive environment to see whether that can drive innovation and promote access to individualized gene therapies. And it's hoped that we will learn something from that effort that will, the phrase "a rising tide lifts all boats," that in that effort to figure out how to develop, test, and deliver therapies to very small diseases, we'll learn things that'll help with larger development programs in the community as a whole. So it can be questions like, how do you leverage preclinical and CMC data, or learn about innovative trial designs that might facilitate development, and even simple things like the use of master files, procedurally, like what's the most efficient way to help manufacturers submit, those who have a platform technology. So those would be some examples of what we're doing. And maybe that was too long-winded, maybe.
No, it was wonderful, and we can't thank you enough. I think that neutralizing antibodies for patients and families to understand what the testing means and whether it applies to all serotypes would be impressive. I think how to handle the complement response when these children get a virus and have a response to that, and if that could be generalized, and certainly data and looking across. I think all of these things are so important for our families and for the world of rare diseases. I can't thank you enough, Dr. Witten, for what you do, for how you communicate with all of us and how you're working so hard. If there's anything we can do to help you accelerate, our fingers are crossed and we're hopeful to get a home run or even a near home run in gene therapy. So thank you for joining us tonight, and we hope to see you very soon.
I appreciate that. And I just want to add one last word, which is we appreciate the efforts of the patient communities, and we're looking forward to seeing the guidance document as you develop that.
Thank you. Thank you. We're thrilled to be developing that guidance. Thank you again. We'll see you soon.
Thank you so much, Dr. Witten and Pat. It's really good to hear about the guidance development too. So we are going to turn now to our polling, the last polling of today. Go to pollev.com/PPMD in order to participate. Understandably, we're going to ask some questions to start with about gene therapy, given that this was the topic du jour of the day. Knowing what you know today, how comfortable would your child be joining a gene therapy clinical trial? We're seeing answers just start to come in.
Yeah, and we've done some preference work on this, looking at benefit risk as well, about trying to understand, the level of comfort that families do have. Obviously, we didn't talk about it as much in that session, but as was alluded to, there are risks with gene therapy, and so those are things that, of course, we want to make sure that all of our families are educated about and knowing as they can, look to participate in those trials.
Yeah, and some of you participated in that original preference study we did. We're excited to go back out partnering with Duchenne UK in the coming months to engage you on your preferences once again. Preferences change over time as new knowledge is gained. So it's really important to measure these things over time. We've engaged the FDA on this informally, and they're going to be providing feedback informally. I stress that again. But we're seeing the answers here, a large percentage, a high percentage are either comfortable or very comfortable, somewhat comfortable and neutral, coming in at around 20%.
And when we do collect that data, looking at benefit risk, I mean, that's important for decision making and for talking with regulators and companies about kind of what's acceptable. And as well, I mean, that's a great way for us to capture the patient voice and to put it in front of those groups and say, you know, here's what the community feels about, you know, these products. And so we really do appreciate when we can capture your voice like that.
Absolutely. It's true patient-focused drug development. Okay, we can move to the next polling question. I thank everyone for answering. So imagine a scenario in which you or your child has the potential to join a gene therapy trial. What would you need to know to help make a confident decision to join? You can choose your top 2 here. You should be able to make 2 choices.
Yeah, and there's a lot of different kind of options here. And you know, not surprised to see that some of them coming in are talking about recommendations from the doctor or existing data on safety and efficacy based on humans. That's kind of the conversations that we expect to have happen is you having those conversations with your doctor about what this looks like for you. But we are, of course, interested to see, you know, what else is it that is important to this community that we should be conveying to them.
And we're seeing not many yet choosing some of the responses, but keep them coming. You know, it's hard and to choose amongst the list, but we're seeing that, not surprisingly, that access to the safety and efficacy data on human studies would be very helpful to the decision making.
Yeah, and the preclinical animal studies, I mean, that could be very hard to interpret if you don't have a background in it. So not a surprise to see that down a little lower.
Yeah, absolutely, absolutely. And I think for these first, you know, sets of gene therapy trials, there is limited data. So there's uncertainty there, and really our appreciation goes out to these families who have to make these choices, and you got to make these choices in consultation with your family and physicians, and however best you feel. This is a personal choice at the end of the day. Okay, I think we can move to the next. Okay, over the past 2 years, how often has your or your child's doctor talked to you about trial opportunities, not just gene therapy trial opportunities and advances? So we want to understand all trials that are currently in development.
Yeah, and this is the kind of information that we like to take whenever we have some of our meetings with our CDCCs or our other healthcare meetings, so we can say, you know, here's what we're getting from the community about how often they're being talked to. You know, you need to reach out more, or you're doing a great job. So this is always, you know, good for us to kind of see, you know, how often these conversations are happening.
Yes, and again, we've asked this question before, but it's important for us to re-ask these questions, because if we can compile all the data, it gives us a better sense of what's going on. And we do appreciate you participating in these polls, because they're so informative to everybody in our sort of drug development and care ecosystem. We're seeing that the higher percentage is leaning in on very often at almost every clinic visit.
And again, this might be a reflection of the center where you're at and where you're seen. You know, if your center doesn't have clinical trials, then there's, you know, a chance that they might not talk about them quite as often. Whereas if you're at one of the centers where we have a significant number of trials active, you know, that may be a routine part of your discussion.
It's true, and I think many families are bringing the conversation themselves to their clinician. They may be initiating the conversation about a clinical trial for that discussion. So I think with that we can move to the pop quiz question. Is it the pop? Yes, pop quiz. So for all our Star Wars fans, the Jedi Council consists of how many members?
Wow, this is when I have to see if I can do recall. I think 11-year-old me will be very disappointed if I don't get this correct.
So like 10 years ago, right?
Thanks, Ryan.
Okay.
Did you have a favorite Jedi growing up?
Chewbacca.
Oh, great. Very helpful. At least you didn't say someone from Star
Trek. I really
Trek.
did connect.
Yeah, I can tell.
I've fumbled my words as much as he has, so. Seeing 12 as the one that's being chosen the most, followed by, screen's cut off, 9 there.
Yeah, it looks like 12 is the predominant one, with 9 coming in second at the moment.
And remember, the person who answered the correct answer first will win $25. We'll announce that at the end, but let's now reveal the answer. Let's see who. Answer's 12. A lot of you got that right. A lot of Star Wars fans. That's fantastic. Okay, we will announce the name of the winner after our last presentation.
And with that, we are going to take a moment to spotlight some PPMD programming and funded research before we return with some recently reported updates from PTC Therapeutics.
During the last year, PPMD gave us a bridge funding grant to basically bridge a funding gap we had because unfortunately the year before our Wellstone Center was not renewed, and so we had to recompete it. The good news is that we were successful in the revised competition, and so our Wellstone Center will be funded by NIH again beginning August 1st. And so in that regard, the bridging grant from PPMD was highly successful. But more importantly, it allowed us not to stop on the work that we think is very important for the Duchenne community. And namely, that is to examine all of the current microdystrophin gene therapies, all the AAV gene therapies that use microdystrophin that are currently in the clinic or going into the clinic, to really better understand what they mean in terms of stopping or slowing disease in a much more severe mouse model than the one that a lot of them were tested in initially. And so we've been using a much more severe mouse model to look at this. And according, indeed, it doesn't stop. None of the therapies stop the disease, but they do make it look more like Becker than Duchenne. So it greatly slows the disease. So over the last year, we've been focused at identifying what is not being fixed by these microdystrophins, with the idea that we could maybe augment the current gene therapies with either other drugs or maybe other types of gene therapy could be given in combination with them going forward. But one way or the other to try to greatly slow it even further or maybe stop the disease progression if we can identify all of the shortcomings. At the same time, we're trying to see if we can get even better microdystrophins than the ones in the current trials. But it may not be possible given the limited capacity of AAV. So one way or the other, either through pharmacological means, giving dual vectors or better microdystrophins, we're hoping we can improve the current generation of gene therapy so that it just slows the progression of disease to an even greater extent in DMD. And that's what our bridging grant was about. And that's what our Wellstone Center is going to focus on for the next 4 years now that it's been renewed by NIH.
Hi there, we're the Friars. We are so excited to share with you how you can raise funds for PPMD by creating your own DIY event. Whether it's in person or a virtual event, PPMD has all the tools to help you create a fun event right in your own community. Our family hosts 2 annual events for PPMD, a golf outing in July and a 0.1K in November. Doing your own event is a great way to get your family and friends more involved. A 0.1K is super easy and really fun. It's only 100 yards or the length of a football field, and it can be done anywhere. PPMD can provide you with an event website, mobile auction software, PPMD swag, and so much more. They can make it so easy and fun too. Visit parentprojectmd.org/DIY to learn more about how you can create your own in-person or virtual DIY event.
Welcome back. Next up, we're going to be joined by Dr. Craig McDonald to share some recently reported updates from PTC Therapeutics comparing deflazacort and prednisone. So Craig, go ahead and take it away.
Well, thank you very much, Ryan, and I would like to really focus here. Could I see the first slide again? I'm sorry, I'm not seeing a slide. Could you? Ryan, is there a slide deck?
Yep, slide should be up.
Okay, great. Well, it's really my pleasure to present here this new data. I'm not, let me just go to gallery view here. Okay. Let's see, it's a, is there a way to enlarge that view? I'm sorry.
Okay, Craig,
Oh, there we go. Great, thank you. So again, what I'd like to do is present some recent data that we have looked at with regard to deflazacort versus prednisone. Again, I'm having a hard time seeing the slides here. Recently is taken another look at some meta-analyses on some placebo-controlled data sets where in the placebo groups, we actually were able to evaluate comparisons of patients in the placebo arms of clinical trials treated with Emflaza or deflazacort versus those who were treated with prednisone. As you are aware, deflazacort is the only corticosteroid approved specifically for Duchenne in the US for patients aged 2 years and older. And thus far, a number of meta-analyses have supported the benefits of deflazacort over prednisone, looking at a number of clinical efficacy endpoints. And today we're going to actually revisit those meta-analyses looking at important subgroups of patients treated with these two medications while being in the placebo arms of various clinical trials. If we could go to the next slide. Next slide, please. So again, the early initiation of corticosteroids have been shown to translate to better overall outcomes for Duchenne patients. So we believe that if steroids are started earlier in the course of the disease, there'll be better function and prolonged time to loss of very important milestones in a Duchenne population. Next slide. This is actual natural history data from the CTAP consortium, actually looking at the rise from supine time on the left and the North Star time, various trajectories. What you can see there on the left is that the horizontal line shows a 5-second rise time, and patients that are below a 5-second rise time actually have fairly stable functioning. They may actually be showing improved functioning, but fairly consistently, those with rise from the floor times of greater than 5 seconds has very precipitous declines in function. Similarly, on the right, those that are younger than age 7 to 8 years of age oftentimes are in a maturational trajectory where they're actually showing improved function on the North Star, but fairly consistently, those who are 8 years and older show decline on the North Star ambulatory assessment scale. So for this study, we actually were interested in looking at differences with treatment of deflazacort versus prednisone for patients who are above 5 seconds on the rise time or below 5 seconds and above the age of 8 and below the age of 8. Next slide, please. As far as the objectives, they were to evaluate daily deflazacort versus daily prednisone in patients with Duchenne using data from the placebo arms of the two PTC trials, 007 and 020, and the Lilly tadalafil trial, and to compare daily deflazacort and daily prednisone in key Duchenne patient subgroups. Those of baseline age of 4 to 8 to less than 8 years of age, and those who were greater than 8 years of age, and then also looking at those with time to stand from supine of less than 5 seconds versus those with a greater than 5 second rise time. and also those with previous corticosteroid treatment duration of 0 to 3 years versus those who were greater than 3 years. And I think these subgroups are certainly of interest because the 4DMD clinical trial, which has completed, we don't have the readout of the results yet, but that trial was largely conducted in patients who were 4 to 7 years of age, and those patients were followed up for a total of 3 years. So we're really asking the question as to whether there's differences with deflazacort and prednisone in patients who are more progressed with regard to their disease severity and older. Next slide, please. So we actually had a lot of placebo data from over 200 patients to actually evaluate a comparison of daily deflazacort and daily prednisone. And if we look at these trials, the 007 trial was conducted in patients greater than 5 years of age, the 020 study in patients 7 to 16 years of age, and the Lilly tadalafil trial was conducted in patients who were 7 to 14 years of age. The 6-minute walk test was the primary endpoint. There were also time function tests obtained, but we have actual placebo data on patients with daily corticosteroids in 30 patients from the 007 trial, from 84 patients from the 020 trial, from 85 patients from the Lilly tadalafil trial. Next slide. So again, the data we will focus on today is pooled studies focusing on key measures of physical function, the 6-minute walk distance, time to climb 4 stairs, descend 4 stairs, stand from supine, and the North Star ambulatory assessment. So again, these are all patients who were treated with either daily prednisone or daily deflazacort. Some of the previous meta-analyses also included patients who were on intermittent regimens of prednisone. Next slide. So in comparing these groups, very similar age groups among the prednisone treated and the deflazacort treated, similar anthropometric measures. The corticosteroid doses were actually very similar as a percent of the recommended initial corticosteroid dose. So 75.5% for the deflazacort treated patients in terms of their recommended deflazacort dose, 74% for the prednisone treated patients in terms of their recommended prednisone dose. And these patients were on average on these regimens for about 3 years duration. Next slide. So with regard to the 6-minute walk data outcomes, looking overall at the overall population, there was about a 33-meter treatment effect favoring deflazacort over the prednisone treated group, statistically significant. If we could go to the next slide. Similarly, in the overall patients, there was overall improved function on time to climb 4 stairs by about 2.7 seconds and time to descend stairs by 2.2 seconds. Again, both statistically significant and a nearly significant effect favoring deflazacort for time to stand from supine. If we could go to the next slide. The linearized North Star score also showed better outcomes on the overall linearized North Star score by about 4 points for deflazacort treated patients in relation to prednisone treated patients. Again, statistically significant. Next slide. However, when we look at the subgroups of patients for baseline age, I think we had a large number of patients who were actually greater than 8 years of age, more so than those that were 4 to 8 years of age, and then fairly well-balanced groups in terms of those that were below 5 seconds and those that were greater than equal to 5 seconds. And similarly, fairly well-balanced groups in terms of those that were on the steroid regimens for 0 to 3 years versus those that were on the regimens for greater than 3 years. Next slide. So I think what is really quite interesting is when we look again at subgroups of patients, those who were 4 to 7 years of age actually showed really no differentiation in terms of those treated with prednisone versus those treated with deflazacort. But if we look at the older patients, those who are greater than or equal to 8 years of age, we see an even greater effect with regard to 6-minute walk distance. Similarly, those that have stand from supine times of greater than 5 seconds on the 6-minute walk distance, there was a greater treatment effect favoring deflazacort versus prednisone. And those that were on steroids for a longer period of time, greater than 3 years, show a greater deflazacort effect versus a prednisone effect. Next slide. Similarly, when we look at the time function test, you can see here differences in the data. This is the upper 3 bars show time to climb 4 stairs, and the red data point shows those that are greater than or equal to 8 years of age. The blue data point, those that are greater than 5 seconds on their time to rise, and the darker data point is those that are on the steroid regimen for greater than 3 years. And again, we see very consistent benefits across really all 3 time function measures: time to climb 4 stairs, time to descend 4 stairs, and time to stand from supine, favoring deflazacort over prednisone in these more severely affected patients with Duchenne. If we go to the next slide, here's the patients the data from the patients who were 4 to 7 years of age. And here you see less of a clear distinction between deflazacort and prednisone, with no statistically significant differences really between the 2 regimens in those younger patients with lower stand from supine times, and also those patients that were on steroids for less than 3 years. Next slide. Similarly, with the North Star, we are seeing really fairly consistent results across the North Star, both for the younger patients as well as the older patients, and for the less progressed based on stand from supine time, as well as the those that were showed greater disease progression. But again, those that were on steroids for greater than 3 years, we see a greater treatment effect favoring deflazacort. Next slide. So I think these results confirm, at least in terms of efficacy, apparent benefits of daily deflazacort over daily prednisone. Patients on deflazacort perform better in the 6-minute walk test, time function test, and the North Star compared to those on prednisone. There were greater differences observed in patients who were older, greater than or equal to 8 years of age, had more advanced disease progression with stand from supine times of greater than or equal to 5 seconds, and those who were on steroids for greater than 3 years. So I think it's easier to see differences in patients with greater disease progression. And I think these results add to the growing body of evidence demonstrating the potential for cumulative benefit of deflazacort versus prednisone. Again, this study did not look at safety issues between the 2 regimens. And next slide. And with that, I'll end and back to you, Ryan. Thank you.
Great. Thank you so much, Craig. I think Eric has one follow-up question to end us off with.
Yeah, so just if you could maybe give us some insight. So you said, at about 3 years, you start to see some of that separation. About how early do we, after initiating steroids, do we start to see those differences between prednisone and deflazacort? Does it take until 3 years? Does it start showing up earlier, differences in the function?
Well, that's a great question. I think certainly, this was all 48-week data, and mean age was greater than 3 years of exposure. My sense is you probably certainly don't see those differences within perhaps the first year of administration, but there is a cumulative effect over time. I think one of the hypotheses is that prednisone is more fat soluble than deflazacort, and perhaps as the disease progresses and you get more fat fraction or more fatty infiltration into the muscle, perhaps more of the prednisone is taken up into the fat compartment, whereas deflazacort may be more bioavailable to muscle fibers. That's just one of the hypotheses, but a great question.
Oh, great. Well, thank you, Craig. We really appreciate you taking the time to share that data with us.
Great. Thank you so much, Craig. We appreciate it.
Great. Thank you both.
Wonderful. So we are actually going to announce the photo winner and then the polling winner. Let's start with the photo winner, Henry Nilsson from California. Awesome, awesome picture. We love this. Did a really great job. We're excited that tomorrow's challenge is going to be PPMD Spirit Day. So wear your swag, wear your t-shirts, glasses, hats, anything. Please continue submitting these pictures. It's been a great addition to this year's conference. And I'm excited to announce the polling winners for the pop quizzes. Our first winner is Darren White II. And our second winner, our Star Wars fan, is Ryan Suskowitz. So we'll be sending you your gift cards. And thanks again for participating in the polling. So just remember to visit the conference hub on the PPMD website for everything you need to know to make the most out of your conference experience. Eric, can you tell us what's up for tomorrow?
Yeah, absolutely. So tomorrow we're going to have a few more of our in the pipeline sessions. So we're going to be talking about investigational products that and approved products looking to reduce inflammation. We're also going to have a session on investigational products targeting mitochondria and the heart. We're going to have a few more recently reported updates, as well as a care panel discussing pulmonary challenges. Also, as a reminder, we will have those Zoom social events for our moms, dads, grandparents, and siblings, so make sure you get registered for that. And then we will have a special closed session for our teens and adults to discuss relationships, social networks, and mental health. So be sure to check your email in the morning so you can get an overview of the day's sessions. We're going to end today with a slideshow showing a number of the submissions that we had for that photo challenge. So we just want to thank you all for joining us. Have a great night, and we will see you tomorrow.